Yes. All right. Attention disorders, whether you call it ADD or ADHD, I think ADHD is the correct term. It's basically, from what I understand, they're just called attention disorders now. Oh, sorry. Yes.
Yeah, sorry. Just to clarify real quick for clozapine.
Yeah.
You said like this why clozapine slide was the only slide we need to know.
Pretty much. Yep. You don't have to know any of the labs or anything. Just know that it requires extra monitoring. That's
Okay.
it. Yep. And it's for treatment resistant.
Right.
Yep. Okay. So anyway, this disease was thought to be more commonly pediatric for a while. However, there's actually a decent percentage of adults that have been found to suffer from it too. The symptom presentation is quite different. Adults might present more depressed or more anxious or in different ways than a child might present as hyperactive or doing poorly in school or something like that. More common in males than females, but actually fairly decent rates in between the two, slightly more common in males. And drugs are pretty straightforward. There's really just like 3 drugs we use, but there's a whole bunch of different stimulants out there. So we'll talk about why you might choose one or the other. But the idea here is that you have some kind of a catecholamine imbalance in the cerebral cortex, miscommunication between your dopamine and norepinephrine systems. So your brain's either clearing dopamine transporter or increase in dopamine transporter density, so you clear dopamine too quickly from the synapse. You're using more than your body can produce. And serotonin has some role, but no one quite understands exactly what it does. Clinical manifestations, probably self-explanatory, but poor concentration, distractibility, motor activity, impulsivity, disinhibition. Feature disrupt at least 2 domains in daily life to qualify for the diagnosis, so schoolwork, family, and peer relationships. Other things, poor self-regulation, hyperactive component, again, not as overt in adults, more commonly in kids. Disorganization and learning disabilities are associated with attention deficit disorders. All right, pharmacotherapy is first line. Psychotherapy may be helpful for addressing and restoring problematic behaviors, but it might not get at the root cause per se. Norepinephrine pathway, so using something that manipulates the way your synapses are using norepinephrine seems to be the best at treating ADHD. Stimulants are the mainstay of therapy, and our goal is just to restore your functions of daily living so that you don't interfere with school, work, peer relationships, etc. All right, so stimulant, what they do, they release catecholamines from CNS storage sites. So they increase synapse norepinephrine and dopamine. They increase norepinephrine and dopamine in the brainstem, midbrain, and frontal cortex, so kind of all over the brain. They're actually really safe drugs at low doses. I think stimulants get kind of a stigma behind them because people abuse the heck out of them, right? I mean, these are probably the most highly abused drugs in the country next to opioids. So they get that bad rap, but if you actually take them at a normal dose, it's not like taking a hit of methamphetamine, right? that's going like way beyond the spectrum in potency and dose. So if you're doing like an oral stimulant, really, really safe. There's actually not a lot of side effects with them, believe it or not. Caution and former current substance abusers for obvious reasons. If you have an addiction history, probably not the best choice. More effective in children than adults. Shown to improve daily living skills. There's no real difference in efficacy between the different stimulants on the market. Just really a preference of your release mechanism. That's the difference that I'll talk about here in a second. Good short-term benefits, questionable long-term. So the short-term benefits are pretty well proven clinically. The long-term benefits, we don't really know, and the studies that do show it don't really show a huge benefit in taking stimulants long-term for life improvement, quality of life improvement, interestingly enough. Okay, a couple different chemicals out there. Methylphenidate is aka Ritalin. So the short-acting, intermediate, and long-acting, this is really going to break down what comes into play. I'm not going to test you on all these different things. What I'd like you to know is a couple items. So I want you to know a few different products, so just so you don't have to memorize these whole lists, because I don't think it's worth it, and I can't even keep them all straight. All right, so short-acting, Ritalin comes as a generic, immediate-release product. It lasts a few hours. And that was one of the first drugs available that was a stimulant approved for this condition. Obviously, a few hours isn't great, so if we can extend that so it lasts an entire day, that's good. But we don't want it to go into the evening where it's keeping you up all night either. So obviously, stimulants are the opposite of sedating, right? So even if you're taking the right dose, you're probably still going to be more alert and awake than you would if you weren't taking it at all. So making sure that drug tapers off towards the evening hours so you can get some sleep is important. So most of these try in some way to accomplish that, and you'll see lots of different creative ways to do it. So for example, one way I see a lot is people might take like a long-acting drug in the morning, and then they might take a short-acting drug in the afternoon, early-wise, and then that kind of bridges them into the evening hours. Or they might say, you know, when I get home, I don't really need that. I'm okay. I just need to concentrate more at work, or my attention deficit kicks in more while I'm working or at school. So that's where I need the drug. When I get home, I don't really need it as much. But some people might want it throughout that entire basically waking hour. So it depends on the person, depends on what they're using it for. Some people may take it as needed, and that's a little bit controversial. So, but the point is, there's lots of different products available. I think the one I'd recommend knowing is Concerta. Concerta is a really popular choice. It actually comes as a generic. However, the generic product is technically not an exact equivalent. Concerta's got this really interesting release mechanism. So it has these shells, and you can see it broken up here. What happens is the shell is osmotic, so it allows water to pass through its membrane but it's sort of like a hard plastic. I think of it kind of like an eggshell, but a little bit porous. So anyway, water can go through, and then as water gets in, it pushes the drug out slowly, and then or quickly at first, and then more slowly. So the density of the drug depends on how fast it's going to release from that shell. It's kind of a unique delivery mechanism. Again, it's a really popular choice because of that release mechanism. It gives you sort of a fast onset with then a nice delayed release effect throughout the rest of your day. So Concerta has been widely used, very popular choice for that reason. Some other interesting stuff that I won't talk about, or won't test you on and talk about very much, but Daytrana is a patch. So if you have a kid, especially, I don't think of adults as using these, but if you have a kid who would not take their medication, or you want something they don't have to remember to use, patches might be better. There's also a suspension for people who don't want to take pills that's extended release, little like granules. So lots of different options out there. Just in case you're curious to look at like the duration of action. So if you look at, they don't actually have just a regular dose of Ritalin on here, but if you look at like Ritalin SR, which is the X's, you kind of get that peak around 4 to 6 hours, and it's pretty much out of your system by, I don't know, 10 hours or so. Not a bad option, but it's got this big curve on it, so can you blunt that a little bit? Compared to Concerta, here you get this immediate effect, and sort of a slow release, and then sort of a burst, and then a tapering off. You get a little bit more area under the curve later throughout the day with this drug. So again, this is all the same drug. It's all effective. It just depends on how your patient wants to take it, which one's going to work best. Lots of these formulations get mixed and matched. Lots of them get used. Not like one's really that better, much better than the other, but there's some creative pharmacokinetics at work here. Other stimulants, dexmethylphenidate is Focalin or Focalin XR. So it comes as immediate release, extended release. Dextroamphetamine, Dexedrine, Dexastat, Dexedrine Spaniels, long-acting. Adderall is actually amphetamine mixed salts, so it's a combination of dextroamphetamine and some different amphetamine salts mixed together at different doses. It's a little confusing, but it comes as a immediate release, generic Adderall, and then Adderall XR. Both products are actually generic now. Most of these products are actually all generic. The only exception here is Vyvanse, is brand name only. It's a really popular long-acting one. Why? I'm not entirely sure why people like it better than other ones, but it seems to be a relatively popular choice for long-acting stimulants in patients. All right, side effects. Cardiovascular, more concerning in adults than children. Basically, increased blood pressure and heart rate. So if your patient has underlying hypertension, other cardiovascular issues, probably not the best choice for them. Neurologic, psychiatric, sleep disturbance, obviously. If you get that too close to bedtime, that's where you're going to see it. ADHD also may cause sleep disturbances. So actually, counterintuitively, if you treat this by, I always tell people are like, I think the whole idea of ADHD is a little counterintuitive, right? You take a stimulant to calm down or focus more. I think the way I think about it is that if your brain is really overproducing a certain hormone, or it's overutilizing a certain hormone, these drugs help kind of like funnel it or channel it more so. So I think about it like if you open a pop can and the fizz shoots out right away versus if you like opened it really slowly. So it kind of regulates the way your body can process and release the neurotransmitters versus your body releasing them overly aggressively. So that's how I look at it. Whereas somebody who doesn't have ADHD, if they took the medication, yeah, they're probably going to get a kick of those hormones. So it's going to affect them differently than somebody with the disease. But will they be able to focus? Yeah, they're going to be probably kind of wired, right? Like if they drink a bunch of caffeine, but a little bit differently. Okay. Anyway, sleep disturbances, appetite suppression, tic development, abuse potential. Not a whole lot of things going on here. Most of this is pretty good. The one thing I will say, appetite suppression for kids can be problematic, and that's thought to be associated with growth stunting as well with these. So some kids, it's recommended in some cases to have drug holidays. So kids will take these during the school year and then they'll stop them for the summer. And that's thought, actually, studies have shown that kids who get growth stunting during stimulant use will catch up later in life. So it all kind of averages out at some point. So it's not like it's a permanent thing that they're going to be really short because they took stimulants. Priapism. So males of all ages. It's kind of a rare effect. I think of any time you manipulate norepinephrine and serotonin, there's always some risk you could get an unwanted erection that does not go away. And of course, that can be a medical emergency in some cases, so just something to be aware of. It tends to be more common in stimulants than other medications out there. Some other pearls, I talked about drug holidays. PRN, again, a little bit controversial. So if you need it PRN, like why do you really need it at all? Shouldn't this be like a daily thing if this is truly a disorder you have? I feel like PRN kind of borderlines on abuse personally, but it depends on the person. Some people may have like a really low grade ADHD, and maybe they just need it a couple times a week in the evening or something like that to help them focus on getting housework done. It doesn't really affect their work, affects their home life more so. So you can see some maybe situations where it's appropriate, but I think it's also a little bit questionable if you're taking it as needed only. A lot of people will have like a long-acting on board daily, and they might have an extra dose they can use as needed. I think that's much more common to see. Growth retardation, talked about that. Withdrawal, if people stop these suddenly, it's usually pretty mild, but it depends on the formulation dose and how long they've been on it. Higher doses, longer time, more extended release, or quicker release is going to cause more withdrawal usually for patients. And probably going to exacerbate and cause some rebound effects of the underlying disease, right? All right, that's stimulants. Talking about a couple other drugs quick. Atomoxetine is Strattera. Strattera is a norepinephrine reuptake inhibitor. So think about our SNRIs or SSRIs. This one's just a pure NRI. It's not addictive, it's not controlled, and it's non-stimulant. It is effective, but not quite as good as stimulants in clinical trials. It's brand only. Actually, I think it went generic recently, so ignore that. Adverse effects: fatigue, insomnia, dry mouth, headache, weight loss, GI issues, some erectile dysfunction potentially, also causes priapism rarely, rare but severe hepatotoxicity, and can cause some CV effects like our other stimulants do. So maybe not the best choice for a CV patient still, but this is a good alternative for somebody who doesn't want to take a stimulant or isn't getting good effects out of stimulants or finds the stimulants keep them awake too long, or this can cause insomnia too, but I think it's less than the average stimulant. So certainly a good alternative option, but generally thought of as second line to stimulant therapy. If you had somebody with abuse, though, this would be a first line option.
How does it cause erectile dysfunction and is it like a dose thing?
Yeah, maybe. I think the priapism is just a really rare reaction that can happen with some medications. So erectile dysfunction, probably more of a common thing seen with it, and then rarely reporting that as a higher incidence than the average med. Yeah, kind of bizarre. All right. Antidepressants can be used. A lot of times, again, adults present with some depressive-like symptoms too, and there's some studies that show that combining therapy can be helpful in those patients. So an antidepressant and stimulant. However, if you didn't want to use the stimulant, tricyclic antidepressants actually have some decent response rates by themselves for ADHD. We talked about tricyclics as not being ideal. They're anticholinergic, they're sedating, but it could be an option to try and sedate potentially. Bupropion has more stimulant properties than TCAs. Not sedating, 2 weeks to response. It's been shown to be somewhat effective for attention disorders. MAOIs, don't worry about them. You wouldn't use them in this case. I don't think there would ever be a situation where you'd use them for ADHD, but I could be wrong. It'd be really odd. SSRIs and SNRIs really not going to be used as monotherapy. They're going to be used as an adjunct option to treat the depressive symptoms after whatever you prescribed for the ADHD isn't quite working. Kind of in their own tier, alpha-2 agonist guanfacine is 10x or Intuniv, and Intuniv is the extended release product, 10x is the immediate release. I think 10x is brand name, and I believe 10x is generic, so immediate release is generic. Intuniv is still a brand product, a little bit expensive. Children and adolescents is going to be the most common. use for this for adults. It's just doesn't have a lot of evidence behind it. It might work. It might be worth a shot, but who knows? We just don't have a good body of evidence to base that decision off of. If children have aggressive behavior or significant hyperactivity and stimulants seem to enhance that, which can happen in some cases, this is a great option for those kids because it's going to work on a different mechanism. So the alpha-2 agonist thought, remember clonidine, our drug for hypertension? Guanfacine is actually kind of similar in how it works. So it works on the alpha-2 receptors in the central nervous system and agonizes them. It has kind of a psychomotor downstream effect where you get some some inhibitory responses. So in clonidine, it decreases blood pressure, and actually guanfacine would probably do that too. You just don't really notice it quite as much in kids, but it has some effects in just how their brain processes the information. It's kind of a unique mechanism of action. You can combine guanfacine with a stimulant too if you wanted to. So if both work for that patient, could be an option. I think of clonidine as like the male or female adult patient with hypertension, and you don't have a good option. You don't want to give them a stimulant. Probably don't want to give them atomoxetine. Clonidine might actually work well for their blood pressure, and it actually might help with their attention deficit as well. So that's my recommendation for somebody with those cardiac comorbidities. Stimulant abuse, I mentioned this already. Stimulants are all Schedule II. There's prescription limitations with those. Usually you can only prescribe a month with a Schedule II. I think there's some states, I think Minnesota is one of them, that allow you to do 90 days in some cases, depending on if you can prove the patient's been on it for a while. College and high school student abuse is rampant, as probably everyone knows. I don't need to tell you this. Thought of it as a study drug, whatever. I had this roommate in college at Bethel who would he would go in and try and get like the weirdest drugs. And one time he got prescribed Zyprexa because he was trying to get Adderall from a psychiatrist. They ended up giving him Zyprexa. I don't know why. I think they thought he was bipolar, and I'm not sure if he was faking the symptoms or what. It was bizarre. Who knows what happened? I didn't know enough about drugs at the time, but I think back on that, I'm like, how is that even possible? Like, you prescribe somebody Zyprexa and then never follow up with them? It's really bad. So anyway, he took Zyprexa for like a week, and he was just a total zombie. But so anyway, he would have like a pharmacy in his basement. He always had Concerta and whatever, and he'd be like, "Chad, you want his Concerta? You need this." I'd be like, "Oh, I got this test coming out." He's like, "Take a Concerta." I'm like, "I'm good." All right. So
that's where
he was generous, right? So you got to give him that. He's a character. All right. So anyway, also performance arts and athletics. A lot of sports regulatory organizations ban stimulants for that reason, for obvious reasons, right? Slow release of oral stimulants, again, doesn't really produce a high. So the reason that this is the big controversy, right? So if somebody wants to use a drug that's relatively safe, it doesn't really get you high, if you use it in low doses and are taking it orally, if you aren't grinding up and snorting it, right? I mean, that's obviously abuse. But so if you're taking it normally, like, what's to stop somebody to say, hey, I want to do a little better, study harder, and I want to take 5 milligrams of Adderall every once in a while? Is that really wrong? I don't know. That's a dilemma. There's a lot of ethical debate around that. So interesting. I'll leave it at that. I'm not really going to get into it because I don't know if I have a strong opinion either way. Patients are at high risk for abuse. So if you do have these patients who have abused the drug or have abused other drugs in the past, I definitely consider atomoxetine or a tricyclic possibly as a first-line option. All right. Okay, so what about patients without ADHD? I already talked about this, how it happens. Like, why would somebody get an effect if they don't? And yes, they get a stimulant effect, but it's going to work differently in their brain than it would somebody with the actual disease. Okay, treatment strategy, initial treatment, no history of drug abuse. You're going to usually start with a stimulant, pick a formulation. If that doesn't work, switch. Consider mixing long-acting with short-acting. You know, if you wanted to go with atomoxetine right off the bat, I would never fault somebody for doing that. That's fine too. Just the evidence body is great. I think atomoxetine for a long time we've kind of pushed it off, but now that it's generic, I think it's more affordable for a lot of people, and it certainly could be maybe considered something to try starting with if you're really uncomfortable with stimulant use in a certain patient. Especially if you're thinking they have ADHD but are also maybe drug seeking a little bit, getting that kind of spider sense tingling. Anyway, if you have history of abuse or second-line options, atomoxetine, TCAs, guanfacine for kids should be probably your second-line option, or your first line for those aggressive patients or highly agitated kids. Not responding, try different stimulants, maybe combine classes. Look at your release mechanisms. Make sure you're getting the optimal amount at the optimal times for the patient. And then consider adding an antidepressant, especially for adults. Sometimes in kids and adolescents too, they might benefit from like an SSRI adjunct in these. Even if they don't necessarily have depression per se, sometimes it does help. So, all right, any questions on that? All right. I'll give you 24 minutes left. How's that?
Yeah.
Yes.
When I say